Good morning. I'd like to call this roundtable to order. Today is Wednesday, December 4th, 2024, and the time is 11:02 a.m. We are in room 120 of the John A. Wilson Building, and this is a roundtable in the hybrid format with witnesses testifying both in person and virtually on the Zoom platform. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today, we will hear from two nominees to the State Health-Wide Coordinating Council. The State Health-Wide Coordinating Council, or SHIC, advises the State Health Planning and Development Agency, also known as SHPTA, within DC Health. Yes, we like to use a lot of acronyms. So the SHIC assists SHPTA in the development of the district's health systems plan, which is a critical document that guides the district's priorities regarding healthcare infrastructure. The SHIC also makes recommendations on applications for certificates of need, which are required for any new healthcare service or substantial changes to a healthcare service in the district. The SHIC is comprised of 15 members who represent healthcare facilities, consumers, physicians, nurses, and the insurance industry. PR 25-1050 nominates Ruth Fisher Pollard to the SHIC as a representative of an incorporated association of healthcare facilities in the district. She would be replacing Jacqueline Bowens from the DC Hospital Association with a term to end February 11th, 2026. Ms. Pollard is the president and chief executive officer of the DC Primary Care Association, where she works to enhance primary care health services in the district. She is also the executive director of the DC Connected Care Network, a network of DCPCA and federally qualified health centers working to increase quality and decrease costs in the district. She is a Maryland resident. PR 25-1051 nominates Judy Brinkenhoff as a public member of the SHIC with a term to end February 11th, 2026. Ms. Brinkenhoff serves as an immunization compliance nurse at St. Columbia's Nursery School. Previously, she served as a school nurse at Beauvoir, the National Cathedral Elementary School, and Washington School for Girls through the Ignatian Volunteer Corps. Ms. Brickenhoff has also served as a consultant at the Armed Forces Research Institute within the Department of Defense and as an active duty captain in the Nurse Corps for the United States Navy. Ms. Brinkenhoff holds a Master's of Science in Nursing from the University of Texas, San Antonio, and she is a Ward 3 resident. All right. Because we only have two nominees today, we'll have both of you provide your testimony and then we'll ask some questions. But before you begin, Ms. Brinkenhoff, I also need you to turn on your camera and I need to swear you both in.
My camera is on.
Oh, I just couldn't see you. So I was
Okay.
just saying that. Yeah. All right. So if you both can raise your right hand, do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth?
I do.
Great. Ms. Pollard, why don't you go ahead and present your testimony first, and then we'll go to Ms. Brinkenhoff.
Okay. Good morning, Chairperson Henderson and members of the Committee on Health. I'm Ruth Pollard, and it is my pleasure to receive your consideration for my nomination to serve as a member of the district's statewide health coordinating council, SHIC. I'm grateful to Mayor Muriel E. Bowser for nominating me and honored to have this opportunity to serve the residents of the District of Columbia. The SHIC's role in supporting development of the Health Services Plan, HSP, and advising on certificates of needs aligns with my personal values and professional experience. I'm particularly pleased to have this opportunity as my professional journey in public health and healthcare began in 2000 at the DC Department of Health, now DC Health, where I served as supervisory public health advisor and assistant chief of program operations for the Women, Infants, and Children program. Subsequently, I had more than a 10-year tenure at Children's National Hospital in various roles, culminating in my appointment as Executive Director of Advocacy and Community Affairs. Over the course of the next decade, I served as the Vice President and Chief Strategy Officer at Providence Hospital, Executive Director of the DC Developing Family Center, and as a healthcare consultant. I'm also an active volunteer serving in various capacities on governing and advisory boards and related affiliations, including the DC Healthcare Workforce Partnership and Capella University School of Nursing and Health Sciences Advisory Board. However, it is my current role as the president and CEO of the DC Primary Care Association that I believe allows me to contribute the most to the SHIC and to transformative initiatives driving health equity in the District of Columbia. As a native as a native Washingtonian and a leader of the DC Primary Care Association, I have deep commitment to ensuring that every district resident has a fair chance for a full, healthy life. DCPCA's mission to sustain community health centers, transform DC healthcare delivery, and advance racial and health equity is aligned with DC health systems strengthening priorities, health system and workforce capacity, health system strengthening, socioeconomic factors, and physical environment, including structural racism, and health education and communication. I understand that many social and structural factors that impact individual and community well-being, and have dedicated my career to improving health system capacity to meet the diverse needs of all those who call DC home. The SHIC's role in identifying health needs, healthcare trends, and needs of the healthcare delivery system offers me an opportunity to bring my personal and professional experiences to bear at the macro level for the benefit of the city that I love. DC Health has a focus on health equity driven by the insights below. Health is more than health care. Health inequities are neither natural nor inevitable. Your zip code may be more important than your genetic code for health. The choices we make are shaped by the choices we have. Structural racism acts as a force in the distribution of opportunities for health, and all policy is health policy. DCPCA shares these values as I personally do, and if confirmed, I will bring them to bear in my work on the SHIC. As we near the opening of the Cedar Hill Regional Medical Center, it is more important than ever that we keep the focus of the needs of the community and the integration of the hospital into the broader health ecosystem, particularly the primary care system. Only through this focus will we make progress towards health equity and well-being. Thank you, Chairperson Henderson, for the opportunity to testify before this committee. Happy to respond to your questions.
Thank you, Ms. Pollard. Ms. Brinkenhoff.
Yes, good morning, Chairperson Henderson and members of the committee. I'm Judith Costello Brinkerhoff. I'm a Navy nurse captain retired. It is a pleasure to receive your consideration for my nomination on the Statewide Health Coordinating Council. I'm grateful to Mayor Bowser for nominating me and have the opportunity to serve. I'm a native of Connecticut, a graduate of Skidmore College and the University of Texas. My family and I have lived in the district since 1994. My husband is a retired attorney with the federal government, and our two daughters attended district schools from nursery through high school. Most recently, I served on the district's Board of Long-Term Healthcare Administration. My successful career as both a decorated Navy nurse, an experienced school nurse, and a member of the Board of Long-Term Healthcare enhanced my ability to make insights into the healthcare training, delivery, quality, and access in the district. For the past 25 years, I've served as a full-time staff member in several DC independent schools. I've worked with children from the early childhood center phase through high school. I pioneered the school nurse role at two schools, and two of those schools were dedicated to children with learning disabilities. I volunteered as the first school nurse consultant at the Washington School for Girls during the pandemic. I presently volunteer at St. Columba's Nursery School as an immunization consultant. I have a full and unrestricted license to practice nursing in the district. I've been a longtime member of the District of Columbia Nurse Association, affiliated with the private and independent school nurse group, and I've been a regular member of the DC Immunization Coalition since 2016. Both my military and school nurse career tracks are relevant to the responsibilities of this board. The professional expectations and diverse experiences acquired as a school nurse in the district, especially during the pandemic, enhanced my ability to assess health issues. My experience with the Long-Term Healthcare Board made me especially aware of training, staffing, risk management, and licensure issues critical to the care of our seniors. In each role, outreach and communication with our colleagues at the Department of Health was essential. Health promotion and communicable disease prevention efforts in schools, just as in hospitals and nursing homes, are a priority. School nurses must clearly communicate with staff and families in an effort to increase student seat time, reduce disease transmission, promote vaccine compliance, and prevent injury. My career has taught me to value the role of adequate sleep, nutrition, and activity. Where clients are limited, accommodations are required. Emergency drills and methods to transport, evacuate must be in place and viable. The hazards of immobility are not unique to long-term healthcare residents. Well-planned and coordinated nursing care is essential. Nurses in schools must manage chronic diseases such as asthma and diabetes. Children in schools experience emergencies such as falls, headaches, seizures, and anaphylaxis. Abuse can occur in any patient care setting. Student misplaced hearing aids, glasses, and insulin monitors. They require defibrillation, EpiPens, and hospital transport. Their health and wellness are governed by district policies and related to annual medical and dental exams, required immunizations, and the DC Nurse Practice Act. Regular and positive communication between the nurse and the family is a key essential component. The clinical practice scenarios and guidelines are not unique to long-term care or inpatient facilities. Prior to school nursing, I spent more than 2 decades on active duty. The assignment that prepares me most for this board was the experience I gained as a nurse executive with both the Navy Inspector General and the Office of Health Affairs at the Department of Defense. During these tours, I wrote healthcare policy and procedures for military medical and dental facilities worldwide. I oversaw quality of care, staff orientation and training, abuse, and safety. Furthermore, I learned to collaborate with all members of the multidisciplinary team, Army, Navy, Marine, and Air Force. Thank you, Chairperson Henderson, for the opportunity to testify for this committee. I would be happy to answer any questions from you or members of the committee.
Thank you. Thank you both for your willingness to testify. Ms. Brinkenhoff, I remember, we had a hearing with you for the Board of Long-Term Care, and then we phrased that board out. So I'm glad that we're still able to utilize your expertise and for your willingness to serve on this. So I have a few questions, a couple of questions for both of you. First, at a hearing that we had on certificate of needs in October, Terry Thompson, who's the current SHPTA director, testified that the new health systems plan could be published before the end of the calendar year. Have you all been briefed on the status of this yet?
No, not at all.
No, I'm not briefed currently. on the
Okay.
status.
Are there anything that you would say off the top of your head you feel like should be most needed updates? The last version of this was published in 2017. So a lot has happened, obviously, in health systems and healthcare since then. And so just trying to get a understanding as the SHIC is supposed to advise on the creation of this plan. Go ahead, Judy.
One of the things that became quite apparent to me when I was on the long-term care board was the preparation of staff. The preponderance of online nursing assistant preparation, some of them with online schools that have up to 10,000 students and 1,000 faculty. And I was quite concerned with preparation, clinical experience, mentoring, quality of care, oversight, supervision, and how we prepare healthcare providers to accomplish their role. And I thought about that with the Cedar Hill Hospital. I read the article in the Post about the number of new staff coming on board and the need to recruit. And I think when the city recruits, we do need to look at preparation, experience, critical thinking, just expertise in healthcare. It isn't an online degree. There has to be some substance there. And I'm concerned about the numbers that we're seeing in healthcare.
Okay. Ms. Pollard?
Thank you. So the new HSP, I will say that we, the DCPCA, my team, as well as members of the DCPCA federally qualified health centers, were actively engaged in the development, participating in several interviews.
Great.
For the new HSP. So very pleased with that collaboration with Terry Thompson and her office. Similar, I think, workforce is definitely one of the key issues that we must continue to address. Again, I said I'm a part of the DC Healthcare Workforce Partnership, led out of the DC Hospital Association, and they've done great work, several annual reports that I think we need to make sure we're paying attention to the recommendations from that report. But also I think that in addition, to workforces, the HSP is designed to help guide where investments should go.
Mhm.
And so, being really keen that if we really want to transform healthcare, that we must invest more in primary care across the city. So I think those are two key things for me.
Great. Ms. Pollard, while we're sort of talking about, I guess, some of the work that you all have done with DCHA, so you'll be taking the seat that DCHA used to have on the SHIC. How do you believe the transition will go? And then two, what would you say about DCPCA also being able to be effective in communicating around decision-making for healthcare infrastructure? There's some differences, obviously, between hospital and primary care, even though there are some overlaps in terms of equipment, but the perspective is different.
Absolutely. Yeah, thank you for that question. I think in terms of the transition, the DC Primary Care Association, the DC Hospital Association have a long history of collaboration, and I see that continuing, and therefore the historical knowledge that Ms. Bowens has brought to the SHIC will not be lost, in the sense that I'm sure she would be happy to transition any information that's necessary to me. Again, you're absolutely right. The Hospital Association is laser focused on acute care, and the Primary Care Association is laser focused on primary care, but we're all part of the healthcare ecosystem. And so we have to work together in order to achieve what we both have in our mission statement and vision statements around, health equity and healthcare access for our community. And so I think that, it's going to be really important that from a primary care perspective, I intend to come with evidence-based facts. I intend to come really helping the SHIC understand what return on investment would look like when we make these types of investment, and using data to drive potential decision-making. So I think that would be key.
Okay, thank you. Ms. Brinkenhoff, one of the things in terms of the SHIC is also sort of helping to advise around challenges that we see in the healthcare systems, where we should be putting some of our priority and emphasis on. You talked a little bit about preparation around healthcare workforce. What might you also prioritize in terms of statewide health planning, and where some of our priority and focus should be in the district?
Well, immunization compliance. I would suggest that if the district were to publish their immunization compliance right now, it would not be an accurate reflection of where our students are. We have a compliance system that shows only compliance that's been entered by schools. So for example, if my school has a 50% compliance rate, that's because I, as the nurse, have only entered 50% of the immunizations into the registry, and that's not accurate. And I became especially aware of that when I was at the Washington School for Girls. They don't have a nurse. They had no one entering immunizations. Their compliance rate was very low. And yet, when I called the parents, they were outraged. They were indignant. What do you mean? Of course I've immunized my children. When I followed up with the healthcare centers, they in fact had a record, but no one was entering the immunization data. So we were able to zoom up to 97% just by getting the right numbers into the system. And I see that as a continuing problem. I'm in a nursery school now without a nurse. And in September, when I look at the roster of 100 children, I might have an immunization compliance rate of 20. When I go through the records, when I call the doctor's offices, we zoom right back up to 95. And the compliance rate is reflected by the school, not by the doctors or the primary cares who are giving the immunization. It's up to the school to enter the immunizations And that's where the compliance comes in. So I think we're really doing better than we show, but we need to fix the system and how we enter the data.
You are definitely speaking music to my ears. I feel like I literally, even just this earlier this week, I have sent my kids' immunization records 3 times to the school, 3 times. And I'm like, all right.
Oh, yeah.
There's too much. Well, and also this is a complaint. I had it on my list of things to talk to Dr. Bennett about, because for years DC Health has been talking about this online integrated system where the information just comes from the doctor's offices once the kid's information is entered, which makes sense because they have the records and you gave me a printout. So like it exists electronically. Why can't this be uploaded and you say, oh, this child, good to go. This child, we haven't no record yet. Um, and I feel like sometimes we use the regionalism of the district as a crutch to not advance on technology. Because someone will say, oh, well, we have kids who get their doctor's appointments in Maryland. Okay, I'm pretty sure we could work this out with Montgomery County. Uh,
That is absolutely true. Uh, Maryland does not enter into the district's registry. Virginia doesn't. And frankly, some of the premier district pediatric offices don't enter in. While some of the places like Unity and St. Mary's and Children's, they automatically enter. So some of it works very well. This all changed in February of 22. It used to be that the health department entered all the immunization data. Somewhere in the process, in February 22, like overnight, there was a change when the burden was put on the schools. Well, it is very labor intensive and it takes a degree of knowledge. You have to know that a DTP with an IPV is a tetanus and a polio. You have to know your immunizations, the CDC schedule. Secretaries can't be entering that information. This is a permanent health record.
yeah.
And it's not getting done unless a nurse does it. And I can tell you there have been many nights and holidays that I've been sitting at home entering data because it's labor intensive.
Okay. I'm going to bring that up. Thank you. It's good to have somebody on the inside on this. So for both of you, as you may know, the committee is currently considering a bill to reform the certificate of need process, Bill 25-948, which is called the Certificate of Need Improvement Amendment Act. The bill would exempt primary care and non-surgical specialty care from the CON process. It also would limit the types of capital projects that would trigger a CON. So for instance, right now, let's say you wanted to do a elevator repair, you have to go through the CON process in order to do that. We are still working on the legislation, so that's why working on the legislation, and also the council period ends in 2 weeks, so we're out of time. But this is something we're going to be taking up in January. Um, do do you believe that this legislation would negatively impact the SHIC's work if passed? And are there any other reforms to the CON program that you would say, hey, we all should give some consideration on X? Ms. Pollard, I think you probably a bit more familiar. I think you might have testified at that hearing.
Yes.
Oh, okay.
Yeah, I think that I did. I know that we submitted some written testimony around the reform of the certificate of need process, and I've been involved in that process in many positions and roles throughout my career in the District of Columbia. And as I look across like my peers, there's some municipalities, states, et cetera, that don't have certificate of need process or have reformed. And I think that it's really important that we do have this type of process. I do appreciate the reform approach, and I want to say from a DCPCA perspective, we were very much in support of the reform of the certificate of need bill. Though I think we made some comments around not exempting hospital-based type of facilities for certificate. So, like an urgent care, sort of dropping next to without a certificate of need is not something that we would want to support. But otherwise, I do think that the reform is necessary. On the other side, I was taking a look, refreshing myself with the annual implementation plan, which typically comes out in between the HSP, the time period between each of the HSP. And I do think that there are opportunities in that annual implementation plan to better engage and provide communication and messaging around the outcomes,
Mhm.
educate council members, educate other stakeholders around what the outcomes are and how we might use that to inform the work that we have ahead of us throughout the entire ecosystem. So, and I think this could be responsible for getting those type of messages out.
Okay. Ms. Birkenhoff, do you have any thoughts on the CON process?
Well, I'm certainly not that familiar with it, but I hear elevators and I think access and an emergency exit. So it's needed all over for young, old, and everyone, staff. You
Yep.
just
Okay. So I asked this of all of our nominees. Ms. Brinkenhoff knows this because she's been through her hearing, but I'm going to assume that you've had conversations with either MODA or DC Health to explain the time commitments to fulfill the duties of the board. And I have to ask and hear in an affirmative, do you have the capacity to fulfill the duties of the board as they have been explained to you?
Yes, I do have that capacity.
Ms. Brinkenhoff?
just a question, is it a monthly meeting? I was looking online at the minutes and I couldn't really find that the committee was meeting once a month.
I think that it in an ideal world, it might be a monthly, but there might be some months, particularly in the summertime, for instance, where they may not meet,
Okay,
say like in August or those kinds of things.
thank you.
Oh, okay. And instead, I'm told by MODA, based on their subcommittees to the full council as well. So there might be additional meetings based on whatever subcommittee that you join. Okay, great. All right. Well, I want to thank you again for your willingness to serve. I think we have all the documentation that we need from you all. This concludes today's roundtable. The committee will hold its next meeting on Monday, December 9th. We're going to vote on the nominees from today's roundtable. And then we're also going to vote on the committee's Council Period 25 activity report. It's been a very busy 2 years. And I actually want to take this opportunity to thank the Mayor's Office of Talent and Appointments. When I first became chair of the Committee on Health, we had lots of vacancies across the 19 boards and commissions under the health cluster. And I'm pleased to report that we have moved 110 nominations in the past 2 years, which is a lot. I will also say too, prior to my tenure as chair, it had been almost a decade since the Committee on Health had actually held hearings on nominees for the boards and commissions. So I appreciate all of you for taking the time to do this, because I feel like it's helpful for us to get a better understanding of your understanding of the roles and responsibilities of the work, but also your qualifications and backgrounds beyond just what we see on paper. So thank you so much. And the time is 11:31 and this roundtable is adjourned. Thank you.
Thank you.